I'm delighted to be able to talk on the capsular plication repair. I wrote the chapter 17 in the book, and I'm happy to share it with you and the delegates of the Wiroc Global. It's as we all know, we deal with two more main compartments in the hip: the central compartment and the peripheral compartment. And the capsule surrounding the hip is in the peripheral compartment. We have the capsule of the hip consists of like a ligamental fibrous structure with three identified external ligaments, and they are directed longitudinally, as well as we have internal fibers going more circumferentially. And we have the three distinct ligaments, and the larger one, the iliofemoral ligament, is in the front of the hip, and this is the strongest ligament. And then we have more medial, the pubofemoral ligament. And then in the back, on the posterior capsule, we have the ischiofemoral ligament as part of the posterior capsule. And the mid portion of the capsule is thickest upwards and superiorly, and this region represents the iliofemoral ligament. And it is also the site where we perform the interportal capsulotomy during hip arthroscopy. So the capsulotomy runs along the rim. And is the capsule important in hip arthroscopy? Yes. In young patients, in women who tend to show greater hyperlaxity, also in patients with generalized or localized hyperlaxity, and in patients with borderline dysplasia, and patients who come easily distracted during surgery, and also with repetitive microtrauma of the hip, for example, ballet dancers and martial arts athletes, and if you, of course, perform a large T-cut capsulotomy. There's a biomechanical study out there from Abrams from 2015, where they investigated different capsulotomies and found that the larger the capsulotomy, the greater the degree of hip rotation. And hip capsulotomy and the unrepaired T-type results in the greatest degree of rotation. No surprise there. So in the early years when I started doing hip arthroscopy, and that's 20 years ago, it was believed that the capsule healed all the time. But nowadays we know from time and experience that in some patients it doesn't heal, and that in some patients they seem to have problems with micro instability and even gross instability, and in few rare cases even outright hip dislocations described in literature, as you see here. So micro instability is probably much more common than we previously have believed. And here we have a diagram of T-cut capsulotomy in open surgery, and here is interportal cut. And I'll try to show you my technique for suturing the capsule. And it's important that you do the capsulotomy about 8 to 10 millimeters from the rim and from the labrum, so that you have enough tissue on the acetabular side, and do not excise too much tissue. Here you have the beaver blade coming in. You have the labrum on the left, and it's about 8 to 10 millimeters away from the rim. So make the capsule, don't take too much tissue away. Now I'll show you in simple steps. You place the camera in the mid-anterior portal. I have the patient in supine. Here you have a picture of the camera in the front, and you have a portal at the anterolateral portal down below. And then I place my first capsular suture in the anterolateral capsule and secure with a clamp on the outside. Here you have the camera from looking down, and then you change portals and release traction. And then I finish my osteochondroplasty in the peripheral compartment. Here's the osteochondroplasty. And then I place a second capsular suture in the front and close the anterior capsule at the end of the procedure. Here you have the front. And then I remove the camera and close the first suture I placed, which was hanging outside. And here's my video of the procedure. So I use a number 2 vicryl suture, and it's an interportal cut. I have the hip in full extension and in traction. The camera is at the mid-anterior portal. I'm using a Acropath Direct. For this procedure, you can use any suture fiber you like. Here's looking from in the front, looking down at the 12 o'clock position. I've done all the label repair. All the intra-articular stuff has been done. And here's the suture coming in with the suture parser. I pass it through the acetabular portion of the capsule. And then I just move the suture a little bit further in so that it's easier to grab, and sometimes it's easy and sometimes it's a little bit more difficult. So it's sometimes you have to pull on the suture from the outside, as I'll be doing in a short while. Just pulling on it outside, so I bring it to the suture parser, grab it, and pull it outside. So it's a double stranded, it's a looped suture. You can see when I'm tugging it on it from the outside, I can also hold the capsule away from the acetabular rim. This is the view from the outside. It's a long suture. It's a 1.20 meters. So I put a pion or a clamp on it and leave it hanging. And then I change portal so that the camera goes into the anterolateral portal in order to be able to go into the peripheral compartment. I changed the camera portal. Now we're looking from the anterolateral towards the mid-anterior portal. I've finished all the label repair and cartilage repair. And then I finish the surgery in both compartments, do the osteochondroplasty. And then at the end of the procedure, I flex the hip into about 45 degrees, place a chafing rod in the front. Then we come in with a half pipe. And then again, using a suture parser and putting in the number 2 vicryl in the front. And then you can suture the anterior part of the capsule. And here I'm delivering in the proximal portion of the capsule, close to the rim, grabbing the suture and bringing it down towards the neck. You see the osteochondroplasty down below. And then you grab the distal portion of the capsulotomy and the capsule, and then you grab the suture through that portion of the capsule, and then bringing it outside. And then you can see when you pull on it, you close the anterior capsule, and in the background you can see a part of the psoas tendon crossing across the rim. And then to end up the suture, you have to do some sort of sliding knot, and I'm using the so-called Quebec city slider, popularized by Dr. Philippon in Vale. It's basically a double loop where you bring one of the strands of the suture through, and then you pass down the suture onto the capsule by tugging on both strands. So you just pull it down, and then you slide 2 or 3 half hitches down with the knot tying instrument. And then at the very end of the procedure, I just pull out the camera, extend the hip, and then I have the first suture I pass. I'll do the Quebec city slider on this part as well. I know that the suture is in the capsule because I put it there. And then just do the same thing, sliding down the Quebec city slider and tying a couple of half hitches on top of it, sliding it down with the nut pusher. So that's basically my technique for suturing the capsule. You can also do capsule tightening with the overlap. And I would again add my thanks for being able to do the chapter in this book. It's been a great pleasure to work with that. Okay.